We are live.
One. We are live.
Okay. Good evening, all, and a warm welcome to day 5 of this PG session. To present anesthesia implications in the diabetic parturition, we have today Dr. Lipika Balyar Singh. Dr. Lipika is the current president ISA Mumbai and professor in Department of Anesthesiology, TNMC and BYLNAIR Hospital. Lipika, you can start.
Good evening, everybody. Today we are going to discuss about the anesthesia implications in diabetic parturition. Here the highlights of the session will be all these topics will be covered in brief. Before that, I would just like to bring you notice to this globally and mostly in the developing country like India, where the hyperglycemia is one of the most medical conditions which is encountered normally first time during pregnancy. Here, it is seen that 1 in 6 live births occur to women with some form of hypoglycemia, and it is seen that 84% of which are due to gestational diabetes mellitus or GDM. And it is very alarming to note that the GDM is on the rise globally, and it is a very high incidence in the low and middle income countries. And only a ray of hope is that the pregnancy, because of the pregnancy, when the patient seeks medical service, that offers a window of opportunity to establish our services and to improve health and to prevent the intergenerational transmission of non-communicable diseases, that is the effect of diabetes mellitus, which gets carried over to the fetus. And as anesthetists, when we provide them labor analgesia or anesthesia for obstetric purposes like cesarean section, then while providing anesthesia, we have to take care of them in this altered or axial. You can see that it's up to 25%. The crude prevalence rate is up to 25%. So we should be, while taking the history and while doing the pre-op evaluation, we have to keep these points in mind, and we have to take the proper history and how to go about it, and what all are important for us in these obstetric group of patients. We will discuss it further. Here, I just want to bring out this situation, which is very unique in pregnancy, that pregnancy induces several physiological changes specific for the endocrine system. And normal pregnancy is characterized by diurnal changes in the plasma glucose and insulin. That is like a mild fasting hypoglycemic state and a postprandial hyperglycemia, which is present there throughout. This normal pregnancy physiology gets exacerbated and becomes a diabetogenic sustained state, that is the gestational diabetic state. And this state peaks at 28 to 32 weeks, and that is due to the increased placental hormones. Like as we know, the placenta is becomes the biggest largest and then it secretes all these hormones like HPL, cortisol, which are insulin antagonists, and that gives rise to relative insulin resistance. As we know, the glucose crosses the placenta, that induces the hyperglycemia in the mother, induces hyperinsulinemia in the child, and hypoglycemia in the child, leading to various changes in the organ genesis. So, what kind of diabetes we can encounter in pregnancy? We know about the gestational diabetes, that can be pre-existing diabetes, which we are encountering for the first time while examining the patient, and it can be a true GDM, which we have caught or we have detected. And if it is pre-existing diabetes, it can either belong to type 1 or type 2. Type 1 is difficult to treat, as the mother will supposed to be on the OHA, and type 2 is insulin dependent, but it is easier to treat in the pregnancy time, as it is more titrable and more predictable response. So coming to the impact of the maternal hyperglycemia during pregnancy, as you can see, the fetal pancreas are getting stimulated and there is fetal hyperinsulinemia leading to hypoglycemia in the child. So what are the risk factors for developing diabetes in pregnancy? For which category of patients we have to be more alert? While taking history, we have to remember all these high risk group and low risk group. And the clinical characteristics we have to look for are the patients who are obese, or the history of diabetes in first degree relative, if there is current glycosuria. Usually all the pregnant patients are accompanied with urine routine microscopic reports, so we can check for it, glycosuria, presence of glycosuria, and previous history of GDM or glucose intolerance in the previous pregnancies, and previous poor obstetric outcome. It is most commonly when IUFT is present, it is most commonly due to a GDM state in the previous pregnancy. If there is history of previous history of macrosomia, it is the unexplained polyhydramnios, that also points towards the predilection of the patient towards developing the GDM or having a diabetogenic state, having a diabetes mellitus state. And the low risk patients are less than 25 years age, and low risk ethnic groups, various ethnic groups are there, and no diabetes in first degree relative but presenting distant relatives. And there is no history of abnormal GTT and normal peak pregnancy, the weight and pregnancy weight gain. All these point to low risk in the patient for developing diabetes mellitus. And previous living birth with no complications also is an indicator that diabetic state was absent before. Coming to the criteria, which are taken either of criteria 1 or 2 or this criteria 1, the fasting plasma glucose more than 7 millimole per liter or 126 milligram per deciliter. The fasting is defined as no calorie intake for at least 8 hours. And or it can belong to the criteria 2, where the symptoms of hyperglycemia and the casual plasma glucose is more than 200 milligram per deciliter, or it is known as a random sample also. RBS can be up to 11.1 millimole per liter or more than 200 milligram per liter. Casual is defined as any time of day without regard to time since last meal. The classic symptoms of hypoglycemia include, as we know, polyuria, polydipsia, and unexplained weight loss. Or we go for the proper testing of 2 hour plasma glucose, 2 hours plasma glucose load, leading more than 200 milligram per deciliter. During an oral glucose tolerance test or OGTT, the load of glucose is approximately 75 gram or more than 75 gram of 100. So, what can be the outcomes of this diabetic state? The first trimester, there can be loss of the fetus, and there can be increased perinatal mortality, and the mother can have hydramnios, and the child with the fetus will be large for gestational age, or can be either of the two, small for gestational age or large for gestational age. And the most common feature is macrosomia. And it is very alarming to note that there is various congenital anomalies become manifest in these fetus. We will discuss that in the next table. And it has implications for the delivery process also, like the fetus can be a preterm delivery, and usually they suffer from shoulder dystocia and brachial plexus injury and clavicular fracture because the babies are usually more than 4 kgs. And because of the large baby, the delivery process becomes difficult. The birth injury and trauma with vaginal delivery is very common, and usually they have more incidence of operative delivery. And in the neonate after birth, usually most commonly and most dangerous finding is hypoglycemia and hyperinsulinemia, hypocalcemia, hyperbilirubinemia, and polycythemia. All these point to affecting the Apgar score after birth, and it can give rise to CNS effects also afterwards. And the neonatal pathologic syndrome can be neonatal respiratory distress syndrome. It can be organomegaly, or it can be hypertrophic cardiomyopathy if the gestational diabetes mellitus is not treated, or the hyperglycemia state persists without any treatment throughout. The long-term impact on the neonate is like can become an adolescent, obese adolescent, and the child will have impaired glucose tolerance and the child will inherit the diabetic state. Coming to the congenital anomalies in infants with women with overt diabetes, it is the most commonly seen the skeletal manifestation is caudal regression. And in the cardiac system, the child can develop situs inversus is more common. It can be TGA, VSD, ASD. And in the CNS, anencephaly, the most common causes due to the diabetic state in the mother. Spina bifida, hydrocephaly, and other CNS system defects also can take place. And anal and rectal atresia can happen due to this state in the mother. And most commonly seen problem in the renal system is duplex ureter in the child, agenesis, cystic kidney, and other renal anomalies. Duplication of the urogenital system, there is abnormality seen over there. So all these skeletal, cardiac, urine, GI, and renal problems can be really prevented by taking care of the mother's diabetic state by following adequate treatment protocols. So how do we identify the comorbidities associated with diabetes? It is important to screen antenatally for associated comorbidities, and it can be managed in a multidisciplinary approach. Along with the help of the obstetrician, endocrinologist, and the patient herself and the relatives, it has to be treated. And the anesthetist should be involved in the third trimester, usually when we go to screen the patient for anesthesia, for elective sections, or when they are taken up for emergency sections, we can counsel the patient on suitable analgesia and anesthetic options. Like always, we have to encourage and make them understand about the choice of labor analgesia in this particular group of patients, which is very, very helpful in giving a better outcome. Almost the complication becomes nil nowadays. And we have to educate them about the benefits of labor analgesia and about their diet and their lifestyle patterns towards. And we have to encourage them to take the spinal anesthesia in comparison to general anesthesia. So how do we evaluate them? The preoperative evaluation of, as we know, usually the blood sugar control, the level of glycemia, whether it is hypo or hyper glycemic episodes, and the hospitalization is needed for if any of this hypo or hyperglycemic episodes. And the investigations we need are blood sugar fasting or postprandial, and HbA1c is just for the progression of the disease, not for any, it doesn't have any implication for providing anesthesia. Then nephropathy, presence of nephropathy we have to assess, we have to look for hypertension, edema, and recurrent UTI history we have to take. And we must look at the result of urine routine and microscopic, and we have to look at the renal function test, like creatinine and 24 hours protein. Then in the cardiac status, we have to ask for history of angina, MI, and there is if there is history of failure, then look for swelling of feet and exercise intolerance. And we must have a look at the resting ECG, chest X-ray, and echo TMT if there is dyspnea and exertion. And if there is any evidence of PVD, so for that we have to ask for history of intermittent claudication, blanching of feet, and non-healing ulcer in the feet, and that we can confirm with USG Doppler. Where we have to go for the macrovascular problems of diabetes mellitus, then we look for all the complications of all these end-organ affection. Like in the eyes for retinopathy, we have to look for the visual disturbances history we have to take, and we have to do fundus examination if there is any positive history. And here it is very important to go for the autonomic nervous system checkup, where we look for the history of early satiety, abdominal distension, and hydrosis, importance, orthostatic hypotension, or syncope. And usually we will go for all the tests I'll describe afterwards, like posterior changes in blood pressure, heart rate variability with exercise, tachycardia response to atropine. All these will be checked with, and then we can know the severity of the autonomic nervous system affection. And when we look for the metabolic electrolyte system, then we ask for a history of starvation, like whether if the patient has gone into ketosis or if there is any presence of infection in any of the sites, any sign of diabetic ketoacidosis we have to look for. And the investigations are urinary ketone is a must then serum electrolytes levels of sodium, potassium, and arterial blood gas analysis. There is diabetic ketoacidosis. Then we have to check the airway evaluation, which is part of our anesthesia evaluation, because there can be scleroderma, diabeticorum, stiff joint syndrome, or prayer sign or palm print test, which we have to conduct to know if we are going to encounter any difficulty in intubating the patient. And we ask for X-ray cervical spine epilateral if it is very severe. I'll discuss about the diabetic autonomic neuropathy or DAN in details now because it is a question. Clinical features. So, what are the clinical features of diabetic autonomic neuropathy? In the cardiovascular system, there will be resting tachycardia, there will be exercise intolerance, there is orthostatic hypotension, and there is silent myocardial ischemia. It is the most common cause of death, which is very unprepared for. It is very like we can't help the patient really. So this silent myocardial ischemia is very hazardous. We must detect it before. And in the GI system, there is esophageal dysmotility, gastroparesis, diabeticorum, constipation, diarrhea, fecal incontinence. Sorry, fecal incontinence. So this esophageal dysmotility and gastroparesis gives rise to increased risk of aspiration. Like as such, the pregnant patients are more prone for aspiration. But here, if they have the features of DAN, then they become more prone for developing aspiration. And the metabolic features are hypoglycemia associated with autonomic failure, and they exhibit anhidrosis, heat intolerance, gustatory, sweating, and dry skin too. Coming to the clinical manifestation of it, exercise intolerance is due to decreased cardiac output in response to exercise in individuals developing this disorder. And there is intraoperative cardiovascular liability. This is very important for us to know because when we provide regional spinal anesthesia or epidural anesthesia, then these patients go into severe hypotension and almost it becomes intractable hypotension because they have this autonomic neuropathy. So here they exhibit orthostatic hypotension, which is defined as a fall in blood pressure more than 20 millimeter mercury for systolic or less or more than 10 millimeter mercury for diastolic blood pressure in response to postural change. The postural change being supine to standing. In patients with diabetes, orthostatic hypotension is due to damage to the different sympathetic vasomotor fibers, particularly in the splanchnic vasculature. And on top of it, when we provide spinal anesthesia and we go for the adequate blockade up to say T1, T2, then the splanchnic vasculature gets more blocked. So here we must plan it very precisely how much segment we want to block in these patients. And as I told you before, spinal myocardial ischemia, which happens due to cardiac denervation syndrome due to autonomic neuropathy, is a very dangerous outcome which can happen in these patients. So how do we investigate this? We have to check the heart rate response to deep breathing, that is the beat-to-beat heart rate variation, and RR variation, that is beat-to-beat heart rate variation with respiration. That depends on the parasympathetic innervation. So we check for the efficacy of parasympathetic innervation by various tests. There is a particular way of going at these tests. I'll describe it one by one. The test for diabetic autonomic neuropathy, as I told you, in the early stage, there will be in the beginning, there will be abnormality of the heart rate response during deep breathing. And in the intermediate stage, when they progress to the next stage, means the hypoglycemia is not treated and the situation is getting worsening. The metabolic state is not getting better. Then gradually the autonomic neuropathy also progresses. So now that will exhibit the abnormality of Valsalva response. That is then you know that the patient has crossed the early stage and reached the intermediate stage. Then the patient goes into the late stage where there is a postural hypotension that leading to the up position change. And these stages are valid marker of DAN. The following factors are ruled out. Before we brand the patient as having DAN, we must rule out the end organ failure or any other concomitant illness. Drugs like patient taking diuretics, vasodilators, sympathetic blockers, or vagolytics, which can give rise to all these postural hypotension too. So there are various criteria while considering the DAN in these patients. So the heart rate response to standing. So how do we test it? This test evaluates the cardiovascular response elicited by a change from horizontal to a vertical position. In a healthy subject, there is a characteristic and rapid increase in heart rate in response to standing, that is maximal at approximately the 15th beat after standing. This is followed by a relative bradycardia, that is maximal at approximately the 30th beat after standing. So 15th beat and 30th beat. In the patients with diabetic autonomic neuropathy, there is only a gradual increase in heart rate. The patient is connected to the ECG monitor while lying down and then stands to a full upright position. The ECG tracings are used to determine to this 30 to 15 ratio and calculated as the ratio of the longest RR interval. And this RR interval found at about the beat 30 to the shortest RR interval found at about the beat 50. Coming to the Valsalva ratio, how do we elicit it? The patient sits quietly and blows into a mouthpiece at a pressure of 40 millimeter mercury for 15 seconds. The heart rate is measured from an ECG, normally increases during the maneuver, followed by a rebound bradycardia after the pressure has been released. So mark it like the heart rate will increase first and then there will be a rebound bradycardia. So the ratio of the longest RR interval after the maneuver to the shortest while blowing is measured and the result is expressed as the Valsalva ratio. This result is usually expressed as the mean ratio of 3 successive tests. So what are the tests? As I told you, the early, late, intermediate, and late phase, stage of the disease progress. We have to look for the. We have to take the adequate information after performing the tests also. So in the phase 1, there will be a transient rise in blood pressure and a fall in heart rate due to compression of the aorta and propulsion of the blood into the peripheral circulation. Hemodynamic changes are mostly secondary to mechanical factors here. Then in the phase 2, the early fall in blood pressure with the subsequent recovery of blood pressure later in the phase. The blood pressure changes are accompanied by an increase in heart rate. Here there is an increase in heart rate. There is a fall in cardiac output due to impaired venous return causing compensatory cardiac acceleration, increased muscle sympathetic activity and peripheral resistance. And in phase 3, the blood pressure falls and the heart rate increases with cessation of expiration. And in phase 4, the blood pressure increases above the baseline value that overshoots because of residual vasoconstriction and restored normal venous return and cardiac output. So these are the 4 phases in which we are supposed to be checking on the variation of the heart rate and the blood pressure. So here you can see the effect of a Valsalva maneuver in a normal person. There is a small increase in BP. Here you can see in a patient with diabetic autoneuropathy, like there is the small increase in BP is lesser than you will see in a normal patient. Coming to the response of heart rate in response to deep breathing. The high frequency variation of heart rate which coincides with breathing is called the respiratory sinus arrhythmia or RSA. During respiratory sinus arrhythmia, the heart rate increases during the inspiration and decreases during the expiration. So here when we are looking for this impairment of this reflex, then we make the patient sit quietly and the patient breathes deeply, evenly at 6 breaths per minute, the rate which produces maximum variation in heart rate. So the result we expect is maximum result. In the result, what we do is maximum and minimum heart rate we take during each breathing cycle. We measure it, and the mean of the differences during 3 successive cycles are taken to give the maximum minimum heart rate. So here you can see the inspiration expiration variation. Increased when the inspiration is happening, there is activation of the stretch receptors in the lungs, chest wall, and heart, and then the afferent from the nucleus solitarius goes to the brainstem. Then from there the decreased parasympathetic tone. From there the signal comes to decrease the parasympathetic tone, and then there is increased heart rate. And in the expiration, what happens? Relaxation of the stretch receptors in the lungs, chest wall, and heart, and then the afferent goes to the nucleus solitarius in the brainstem, and then there is increased parasympathetic tone, and then there is decreased heart rate. So there is, in expiration there is decreased heart rate, in inspiration there is increased heart rate. So now coming to the response to standing. Here the patient lies quietly on a couch and then stands unaided with an ECG continuously recording. And changing from horizontal to vertical, there is reflex vagal mediated response, whereby a rapid increase in heart rate occurs, maximal at about the 15th beat after standing, followed by slowing, maximal after the 30th beat. So here the result is expressed as 30:15 ratio, the ratio of the longest RR interval around the 30th beat to the shortest around the 15th beat. Coming to the blood pressure response to the sustained hand rate. Here the technique is the sustained, or that is actually a simulation of the isometric muscle exercise, that by doing the hand grip for a certain time, the muscle exercise causes a heart rate dependent increase in cardiac output and a rise in systemic BP. A simple test based on this reflex uses a hand grip dynamometer with hand grip maintained at 30% of the maximum voluntary contraction up to maximum of 5 minutes. Blood pressure measured every minute. So up to maximum of 5 minutes, the blood pressure measured every minute. The result is seen as the difference between the diastolic blood pressure just before the release of the hand grip and that after starting with the measure of the response. So coming to interpreting the results of these tests, so the tests reflecting parasympathetic function, like where the heart rate responds to Valsalva maneuver ratio, it is normal if it is more than 1.21. If it is borderline, if it is between 1.11 to 1.20, and it is abnormal if it is less than 1.10. The heart rate or the RR interval variation during deep breathing, that is the maximum heart rate, is more than 15 beats or equal to or more than 15 beats per minute, that is normal. If it is 11 to 14 beats per minute, then that is borderline, and if it is less than or equal to 10 beats per minute, then it is abnormal. Immediate heart rate response to standing, that is 30:15 ratio. It is normal if it is more than or equal to 1.04, and borderline if it is between 1.01 to 1.03, and abnormal if it is less than or equal to 1. Tests reflecting sympathetic function, that is blood pressure response to standing, where we look for falling systolic blood pressure. It is normal if it is less than or equal to 10 millimeter mercury. It is borderline if it is 11 to 29 millimeter of mercury, and if it is more than or equal to 30 millimeter of mercury, the fall in systolic blood pressure, then it is abnormal. The blood pressure response to sustained hand grip, that is the increase in diastolic blood pressure. That is normal if it is equal or more than 16 millimeter mercury. It is borderline if it is 11 to 15 millimeter mercury. It is abnormal if it is less than or equal to 10 millimeter mercury. If we are using all 5, then the patients can be categorized as normal when all the 5 tests are normal or only one borderline value is coming. And then when we suspect a definite involvement, when there is 2 or more of the heart rate tests are abnormal. And we suspect severe involvement, 2 or more of the heart rate tests are abnormal, plus 1 or both blood pressure tests are abnormal, or one of them is borderline. So then we know the Then we know the severity of the autonomic system deterioration in these patients due to hyperglycemic state. Coming to the other diabetic neuropathy, the diabetic neuropathy that occurs in the peripheral nerves, that can be a diffuse distal chronic sensorimotor neuropathy in diabetic pregnant patients. And the other manifestations can be diabetic amyotrophy, autonomic neuropathy, as I discussed before, and thoracolumbar radiculopathy. All these are important because we are going to give them spinal anesthesia or epidural anesthesia. So this has to be documented and elicited and documented. A neuropathy caused by diabetes mellitus does not necessarily worsen during pregnancy. So it is very important to make the patient and the relatives understand this point. Neuropathy during pregnancy can worsen in certain situations, particularly with the IBDM kind of diabetes. And electrophysiological tests have been done, but they have failed to demonstrate induction or worsening more uh, in this period while delivering or receiving spinal or epidural anesthesia. It is very important to pad the points which are prone for damage and maintaining adequate hydration and temperature in these patients to prevent the worsening of diabetic neuropathy. Careful positioning and padding is a must. Coming to the stiff joint syndrome, which is very important for us. This is a significant risk if the stiff joint syndrome is there. It is a very significant risk for airway management, as it can give rise to, or it is an indicator of anticipated difficult intubation as it affects temporomandibular joint, atlanto-occipital joint, and other cervical spine joints. And they usually have short stature and waxy skin also. And these features are due to non-enzymatic glycosylation of collagen and the deposition in the joints, and it is related to chronic hyperglycemic state. So here we look for the palm print sign, prayer sign, and we look for the, along with these two signs, we look for, we do the Mallampati grade assessment of the airway, and we check the head extension also. And it is proved by various studies that in diabetic patients, palm print is the best single predictor of difficult intubation, followed by Mallampati and the prayer sign. So how do we take the palm print? We ink their hand, and then we take the print on a piece of paper, and as you can see the fingers are not touching, like there are no impressions. So that correlates directly with the licoarytenoid joint disposition in the deposition of the collagen or glycosylation of the collagen at the cricoarytenoid joints, which can give rise to difficulty in intubation. So what are the problems associated in this particular segment of patients in pregnancy? The placental insufficiency is more profound. Then if the superimposed preeclampsia can be present, and then there is an angle of diabetic nephropathy, and they should be always evaluated for presence or absence of diabetic ketoacidosis. So coming to the pathophysiology of these conditions, the placental insufficiency manifested as the uteroplacental blood flow index is seen to be reduced from 35 to 45% decrease. And it decreases further in the women who are having uncontrolled diabetes or who have a higher blood glucose level, or the hyperglycemia is more. It is seen that the impairment of oxygen transport in diabetes, that is the RBC oxygen transport, saturation and oxygen tension, they all are impaired in IDDM diabetic patients. So that adds more of their a problem if the GA is given, or where there is a challenge in oxygen carrying capacity. Deranged buffering capacity is seen in infants of diabetic mothers. Here there is increased affinity of the hemoglobin to oxygen in infant of diabetic mothers. So they become more vulnerable to hypoxia. They are unable to compensate. Placental transfer of insulin happens as the insulin crosses the placenta in the form of insulin anti-insulin antibody complexes freely to the child. So the child becomes more prone for hypoglycemia. And a little bit about the superimposed preeclampsia and diabetic nephropathy. The pregnancy outcome is favorable in these females who have the serum creatinine less than 1.4 milligram per deciliter and the proteinuria is less than 1 gram per 24 hours and normal BP. If there is any deviation, like they have any abnormal blood pressure readings or the proteinuria is more, or the creatinine is more, then their outcome is not going to be favorable for both for the mother and the child. The pathogenesis of development of preeclampsia in women with diabetic nephropathy uh, these conditions like presence of endothelial dysfunction, impaired maximal vasodilation, and increased levels of prorenin and markers of cardiac overload also like ANP, BNP are also seen more in these patients. So they go downhill or they worsen very fast. So coming to the pathophysiology in these pregnant patients, as we know, there is decreased effective circulating insulin, and there is increased insulin counter-regulatory hormones like glucagon, catecholamines, cortisol growth hormone, as we discussed before, and in the muscle, there is decreased glucose utilization. Here, I'm discussing about the pathophysiological mechanism of hypoglycemia. So, from the muscle and the liver, there is glucogenesis and neoglucogenesis, which all contribute to the hyperglycemic state in the pregnant patient. There is increased glycogenolysis, and in the muscles, there is decreased glucose utilization. So, this hyperglycemic state will give rise to glucosylation, and that will give rise to osmotic diuresis, and then that gives rise to dehydration. That is one limb of the pathophysiology. Then coming to the adipose tissues, there is increased lipolysis and there is increased ketogenesis. So these two together gives rise to ketosis, and that gives rise to metabolic acidosis, and which presents as vomiting and decreased oral intake. So this also will add to the dehydration, and this becomes the main pathophysiology for onset of diabetic ketoacidosis. The presence or absence of which is a must as part of our PSC protocol. So coming to the management of decay during pregnancy, as we know the pathophysiology, how it happens now, we have to look for the, it is to be checked from the arterial blood gas measurement, glucose, ketones and electrolyte levels at 1 to 2 hour intervals. And the treatment is insulin fluids and the glucose, potassium and bicarbonate. Insulin is always given as low dose. This is from Nair actually. Here the insulin is always given intravenous and the loading dose is 0.2 to 0.4 unit per kg and the maintenance is 2 to 10 units per hour. And here it is important to note that the fluids used for the initial resuscitation are isotonic sodium chloride, and the total replacement is 1 liter in the first hour, and the total replacement in the first 12 hours of 4 to 6 liters will be 1 liter in the first hour, and then half liter to 1 liter per hour for 2 to 4 hours, and 250 ml per hour until 80% is replaced. And to give glucose, we have to begin with 5% dextrose in normal saline when glucose plasma level reaches 250 milligram per deciliter, that is 14 millimeter per liter. And potassium is initially normal or reduced, then infusion has to be set up, that is 15 to 20 milliequivalent per hour may be needed. If it is more, then we have to wait till the level falls into normal range and then add to the IV solution in a concentration of 20 to 30 milliequivalent per liter. Bicarbonate, it is controversial, but still should be always added to the normal saline, at least if the pH is less than 7.1 or even 7.2. Otherwise, later on, at one point, we can't give a lot of bicarbonate to these patients because it can give rise to fetal hypernatremic state. So, what are the glycemic targets? The glycemic targets we are, according to SCOG and ADL, are the fasting state in the venous plasma should be equivalent or less than 95 milligram per deciliter, and 1 hour postprandial equivalent to or less than 140 milligram per deciliter, and 2 hours postprandial it is less than or equivalent to 120 milligram per deciliter. Mark the change, 1 hour is 140 and 2 hours is 120. If it is pre-meal, then it should be less than or equal to 100 milligram per deciliter. HbA1c usually we don't put for the anesthesia this is only as a measure of progress of the disease. And if it is pre-meal, they say that ADA says that Association of Diabetologists, they say that pre-meal is 80 to 110 and 2 hour post-meal not more than 155, but usually we stick to this 140 and 120. So what are the absolute indications for insulin in pregnancy? When there is significant diabetes related morbidity, and suppose we get a very high HbA1c, like more than 7 to 11, then, and if there is presence of ketone bodies in the urine, significant medical morbidity is present, like associated renal dysfunction, associated hepatic dysfunction, and if there is a history of there is a significant obstetric morbidity, like eclampsia, degree of eclampsia is more. Macrosomia, intrauterine growth retardation in the child, hydramnios, all these are indications that a very tight controlled regime should be followed and insulin should be used. Expected deterioration of the glycemia control due to any kind of stress or in the presence of infection is expected, then also we have to use insulin. And if the mother has received antenatal corticosteroid therapy, then that becomes an indication to give insulin to the mother. So how do we give insulin? Total dose usually varies between 0.7 to 2 units per kg per day. That is as per the present pregnant weight. The insulin dose is 0.7 units per kg up to 18 weeks, then 0.8 units per kg from 18 to 26 weeks, 0.9 units per kg 26 to 36 weeks, and 1 unit per kg beyond 36 weeks to term. As that time, the insulin requirement goes high towards the end of the trimester till term time. So that needs a larger insulin unit. In a morbidly obese woman, the initial doses of insulin may need to be increased to 1.5 to 2 units per kg to overcome the combined insulin resistance of pregnancy and obesity. So both factors are combined. So there we can go up to 2 units also. But the adequacy of glucose control becomes very important in an obese patient. So how do we prepare the solution? We prepare the solution like putting adjust the strength to make it 1 unit in 1 ml of 0.9% finesse. And when the blood glucose value goes above 140 milligram per deciliter, we start the regime. Initially, the value of the blood glucose is divided by 100, and then that much is started initially, then to the nearest roundabout of 0.5 units. And if we see that the level of blood glucose is 200 milligram per deciliter, then increase the rate by 2 units per hour. If it is 160 to 200 milligram per deciliter, then increase the rate by 1 unit per hour. Between 120 to 160, increase the rate by 0.5 unit per hour. If there is 80 to 120 milligram per deciliter, then we don't change the rate or we don't start insulin also. Because the risk of hypoglycemia is always lurking. So anytime we see that the level has fallen below 69 milligram per deciliter, we have to stop the infusion and we have to give IV dextrose. And we have to keep on checking the blood glucose level within 30 minutes, and we have to start the glucose infusion again to prevent hypoglycemia. And the patient monitoring is a must, and to keep on checking blood glucose level every hour until it is within the goal range for 2 hours, and then gradually to reduce it to every 2 hours, because after the delivery immediately there is precipitous fall in the requirement of insulin in the mother, so they go into hypoglycemia very fast. So that point has to be kept in mind. Usually we follow this Albert's regime, where we add 10 millimole to 20 to 30 millimoles of KCl, and this is The advantage of adding potassium is that it decreases the adsorption of insulin. In this regime, the insulin gets delivered in a better way. And here we have to adjust in 5 minutes step. And less than 120 blood glucose, then we put 2 units per hour. 120 to 200, we put 3 units per hour. More than 200 is 4 units per hour. And it is very important to remember that the blood sugar targets the universally accepted goal is pre-delivery 4 to 7 millimole per liter and post-delivery is 6 to 8 millimole per liter. Coming to the role of OH in pregnancy, this is seen that usually when they are taking treatment for polycystic ovarian disease, they are put on metformin, which they usually continue or they stop. And that is a category B drug. There is no adverse outcome after first trimester. It's safe and effective, but we must know that the hypoglycemic effect can be still carrying on. So we have to maintain a very tight controlled regime. And glyburide is an alternative to insulin in the patients who refuse to take insulin or beyond 25 weeks of pregnancy. Also, it can be given. Salbutamide and chlorpropamide, they cross placenta and they cause fetal hyperinsulinemia and they prolong the hypoglycemia. So they should not be used. Glibenclamide can be used to a certain extent because it doesn't cause any fetal anomalies or hypoglycemia and it has minimal transplacental transport. So the glycemic management during labor. If the patient is undergoing labor analgesia and the patient is scheduled for section or being observed for being taken off for cesarean section, then towards the late stage of labor, we can start dextrose to maintain the basal nutritional requirement, that is 150 to 200 ml per hour of 5% dextrose. And if elective LSCS, then check the fasting blood sugar at RPS. If it is in target, then no insulin. Then dextrose drip has to be started. And if the patient delivers, then the patient has to be kept on dextrose normal saline till the patient is fed. And no insulin has to be given unless sugars are more than the normal non-pregnant levels. And here, coming to the blood glucose level, here you can see that if the patient is given spinal anesthesia, how much there is a drop in blood sugar level. So if usually in the 90% of the cases we go for spinal epidural anesthesia, so that will cause a fall in the blood glucose level. See, 5 minutes after induction, 5 minutes after before the end, and 30 minutes after the end. All the time the glucose level is low under spinal anesthesia, whereas in general anesthesia it goes high. So there is really no need if we are providing regional anesthesia to give insulin to these patients because the glucose level is taken care of by our spinal gland. So the glycemic management during labor, again, women with hypoglycemia and pregnancy generally don't require insulin during labor, as I told you the reason. The uterine muscle contractions, the labor produces enough increased insulin sensitivity and reduces the insulin needs. And as their IV and oral intake is restricted, they do not require any insulin. So we have to be very careful while starting any insulin drip to these patients who are in labor. So coming to the immediate management once the child is born, the children are born for hypoglycemia, and 50% of the macrosomic infants they can develop hypoglycememia, and there is exaggerated insulin release secondary to pancreatic beta cell hyperplasia. There is increased risk of if the blood glucose during labor and delivery exceeds 90 milligram per deciliter, there is increased risk of hyperglycemia in these children. So what are the metabolic consequences of surgical stress and anesthesia in these patients, which can give rise to a rise in blood sugar level? As we know, the stress of surgery and anesthesia alters the finely regulated balance between the hepatic glucose and glucose utilization in peripheral, that is neoglucogenesis and glycogenolysis in the peripheral tissues. Cortisol increases the hepatic glucose production, stimulates protein catabolism, and promotes gluconeogenesis, resulting in elevated blood glucose level. So the cortisol and the catecholamines are the main agents which cause the rise in sugar in the metabolic pathway. Catecholamine increases the glucagon secretion and inhibits the insulin release by pancreatic beta cells. And there is this increase in secretion of catecholamine, cortisol, glucagon, and growth hormone causes the excessive release of inflammatory cytokines. The increase in stress hormones also leads to enhanced lipolysis and high free fatty acid concentrations. These increased fatty acid concentrations, free fatty acid concentrations have been shown to inhibit the insulin-stimulated glucose uptake. So all these contribute to the surgical anesthesia stress, and the metabolic consequence becomes hyperglycemia. So how do we choose the mode of anesthesia in diabetic parturients in such a setup? When we go for general anesthesia and when we go for regional anesthesia. In regional anesthesia, to this in the obstetric cases, we provide labor analgesia and we provide spinal anesthesia for cesarean section. So if we compare the general anesthesia with the regional anesthesia, there is always general anesthesia is very risky in these patients as there is difficult airway due to all these changes I had described before. And there is gastroparesis due to autonomic neuropathy that leads to increased chances of aspiration in these patients. And hemodynamic alterations are very, very problematic during intubation and afterwards also. And if we are providing regional anesthesia, then there is exaggerated hypotension if we compare with general anesthesia. In general anesthesia, the advantage is hypotension doesn't happen. But in regional anesthesia, we are choosing to give, then we must take care of the hypotension, which can be profound in these patients. Increased chances of epidural abscess formation is another risk in these patients. So we have to be very careful about sterility, about the skin draping and taking care of the sterility by doing any procedure, starting from the placement of the IV line. And there is higher chances of neonatal acidosis. The pH becomes 7.2 and base excess of minus 5.6 millimole per liter is seen when the children are delivered under spinal anesthesia. That means the mother, the maternal hypotension becomes more. The episodes of maternal hypotension and the duration of sustenance of hypotension is more under spinal. So this you must try to eliminate by maintaining adequate MAP pressure, by providing adequate fluids or vasopressors, and even using prophylactic vasopressors, but at any cost, the blood pressure has to be maintained well. And there is higher incidence of cardiovascular depression, it's seen due to higher sympathetic blockade. So when we are giving the block, we must be very precise about the dose given and about the duration of block, which is going to be that much of a higher level. And we have to support the cardiovascular system that time. And the effect of labor analgesia and diabetics, as we see, lumbar epidural block also provides pain relief both for labor and delivery. And it is seen that the fetus of mothers receiving epidural analgesia in second stage are less acidotic than mothers that receive no analgesia. So that is a very, big advantage. And it is seen that epidural analgesia reduces the levels of endogenous maternal catecholamines during labor, and this benefits the placental perfusion. So these 2 points really make it a very good technique for providing analgesia and anesthesia to these patients. And in case of diabetic neuropathy, the regional block gets prolonged. So this point we have to keep in mind, and we have to adjust our doses, and we have to take care of the we have to do proper positioning with proper padding and taking care of the pressure points. So coming to the epidural anesthesia, as we know that give a test dose of lignocaine 1.5% with epinephrine, and then we give different regimes like bupivacaine in the range of 0.06 to 0.125%, 10 to 15 ml of this. And fentanyl, usually we add 50 to 100 microgram in the entire strength of 15, and or we can add sufentanil 5 to 10 micrograms. Ropivacaine is a better choice nowadays. That is that we can take from 0.1 to 0.2%, 10 to 15 ml plus fentanyl 50 to 100 microgram, or sufentanil 5 to 10 microgram. And then the subsequent analgesia options will include the intermittent bolus, which repeats as above strength to maintain the maternal comfort, or there will be continuous infusion, that is 10 to 15 ml per hour. That will contain bupivacaine 0.0625 to the range of 0.125% plus fentanyl 1 to 2 microgram, or sufentanil 0.1 to 0.3 or 1 to 2 microgram per ml. So usually we follow this bupivacaine 0.0625 to 0.125% plus fentanyl 1 to 2 microgram ml protocol. And if we are going for PCA, that is patient controlled analgesia, then we set the initial bolus as 2A, 2B. The basal infusion of 5 to 10 ml of bupivacaine, and the demand bolus dose of 5 to 10 ml of bupivacaine. That is as 0.0625 to 0.125% plus fentanyl 1 to 2 microgram strength, and lockout interval of 5 to 15 minutes, and total 1 hour lockout of 20 to 25 ml, or 4 hour lockout of 80 to 100 ml. And if perineal anesthesia is needed, then we can administer 10 to 15 ml of local anesthetic, that is lignocaine 1 to 2% of chlorprocaine or bupivacaine 0.25%. So this is about the for labor and vaginal delivery through epidural and PCA pump. So coming to the effect of regional or effect of spinal anesthesia on diabetic parturients, it is seen that there is a very high incidence of bloody tap in diabetic parturients, and a higher spinal level is associated with a decrease in core body temperature. For each incremental increase from block level, the core temperature decreases by 0.15 degrees Celsius. So what is the significance of this? So that shows that there is the block is going to be more prolonged, and then we can make out by measuring the core temperature. We can make out the progress of the block, which can so that total spinal or high spinal will not be happening. Ephedrine dose needs to be carefully titrated since there is increased likelihood of hypertension and autonomic neuropathy in diabetic patients. So there can be an exaggerated response if we give ephedrine in the face of hypotension. And patients with diabetes show changes in the walls of the vessels like vasa vasorum, leading in some compromise in blood supply to the nerves. So apart from nerve edema due to altered metabolism in patients with diabetes and decreased blood flow as a result of microangiopathy, prolongation of the spinal conduction can also occur as a result of myelinated fiber deficiency in patients with diabetes. So the block will get prolonged, and the effect of the drugs in the neural sheaths also will be prolonged. So increased CSF sugar can cause increased CSF volume, which can ultimately lead to higher block levels. So we must maintain a very high index of suspicion for the higher block level than we expect to happen normally, and that should be taken care of, as it can cause severe compromise in the hemodynamic status, and that can affect the fetus also, as we saw before, that it can cause acidosis in the cord blood. By that we can check that the child also has suffered due to hypotension, and the spinal level should be checked with alcohol swab rather than pinprick. The level of block achieved should be checked with alcohol swab. So coming to the agents for intrathecal dosing, we are using the normal concentration while giving spinal to the pregnant patients. Like we are giving in the dose of 7.5 to 15 milligram of bupivacaine, and we are adding 10 to 20 microgram of fentanyl. Or if we are adding sufentanil, it can be 1.25 to 2.5 microgram or if morphine, then 100 to 200 microgram. We see that this is the here I'm just discussing about the usual practice of drug dosing and the use of vasopressor therapy. So here just see that here the spinal is given and the vasopressor is administered at 0, 5, 10, 15 minutes. So the effect of ephedrine, methylphenidate and metronidazole on the blood pressure, you can see the ephedrine is the most consistent, and within 5 minutes the peak goes high and the uterine flow is maintained. So till now the ephedrine remains the drug of choice, and methylphenidate also can be used. And here it is very important to note that the use of vasoactive substances like vasopressors and sympathomimetics in diabetics are dangerous due to presence of concomitant microangiopathy. The vasoconstrictor effect of these drugs exacerbate the microcirculation disorders and disrupts the blood supply to internal organs as well as nerves, which increases the neuropathy. So we have to be very predictable and very judicious with our use of vasopressors. And better than that, we must give a precise drug doses for getting our block level. So coming to the effect of the general anesthesia on diabetic Algerians, we know halogen, and isoflurane can inhibit the insulin response to glucose, and that is reversible and that is dose dependent. And if high dose of opiate anesthesia technique is used, that blocks the sympathetic nervous system, but also has the direct effect on the other systems. And all the time the gastric stasis is high, and they have more higher chances of developing aspiration. So metoclopramide should be always used anytime general anesthesia is provided. And it is seen that ketamine can stimulate the function of the pancreas, but at the same time it increases the tissue's need for the insulin. So coming to the key points, it is observed that hydration using the non-dextrose containing solutions uh, is a must, and we must use separate intravenous line. It should not be running along with the solution carrying the insulin. And routine left lateral displacement, which we use for the obstetric practice, has to be practiced all the time. The wedge and hypotension is promptly treated with intravenous ephedrine, and a well-conducted general anesthesia can be used if necessary with good neonatal outcome. As we see that under general anesthesia, the fluctuation of hemodynamics of the hypotension is not very severe, so that clinical judgment should be applied whenever the mother and the baby need it, and careful titration of inducing agents should be done with adequate preloading to avoid hypotension due to autonomic neuropathy. This is a real challenge for us. If we are giving spinal, then it is our clinical priority to maintain the blood pressure well, so that the effect doesn't get carried over to the fetus. And rapid sequence induction should be done if gastroparesis is suspected. So these are the usual pillars of practice when we are giving anesthesia to obstetric patients, and on top of it to diabetic patients. Thank you for the patient hearing. Coming to few MCQs, we just ask tests for Dan are hemodynamic response to Valseva, heart rate response to deep breathing, heart rate and blood pressure response to standing. D, all of the above. Here the answer is all of the above, as we have discussed it in detail. Which of the following are not true in diabetic pregnancy? Increased chances of aspiration due to gastroparesis, increased requirement of insulin during labor, higher incidence of neonatal acidosis after spinal anesthesia, higher chances of epidural abscess formation. So A is true, B is false, C is true, and D is true. Which of the following is an absolute indication for insulin in pregnancy? Presence of IUGR, A, IUGR, B, associated renal dysfunction, C, preeclampsia, D, ketonuria. It is C, preeclampsia. Epidural test dose in diabetic pregnancy, whether A, lignocaine with adrenaline to be given, plain 2% lignocaine is to be given, or to use ropivacaine and avoid the use of lignocaine and bupivacaine, none of the above. The answer is C. We can use ropivacaine and avoid the use of lignocaine and bupivacaine. Usually, what can be the questions from this topic? You are asked in the long case, the tests for diabetic autoneuropathy, autonomic neuropathy. You are asked to describe the test. That can be a short note also. And the management of diabetic ketoacidosis is a question. And insulin regimes, different insulin regimes also comes as a question, like Albati regime is a short note. And you can get a long case diabetes with pregnancy. Thank you.
Thank you, Dr. Lipika, for that comprehensive presentation. Are there any questions in the chat box? Mosam?
No, ma'am. As of now, no question.
Okay. Shall we end the session?
Yeah.
Yes, ma'am.
Okay. Thank you, Lipika, once again.
Mausam?
Yes, ma'am.